the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.
Of the lecture 1, hot topic in curiosity. In this section of this afternoon, we have four lecture. So for the first topic, I would like to introduce Professor Sang-In Choi. He's director of CT Room and 3D Lab, Division of Cardiovascular Imaging, Department of Radiology, Seoul National University Hospital, Budang Hospital, Seoul National University School of Medicine. So he's the editor-in-chief in ASCI Official Journal, Cardiovascular Imaging in Asia, CVIA, former chairman of Scientific Committee, Korean Society of Cardiovascular Imaging. He will present the topic, Integrations of Cardiac CT in Guidelines. Professor Sang-In Choi, please.
Thank you very much, Chairman, for your kind introduction. Okay, there has been a exponential growth in cardiovascular imaging, resulting in the requirement for guidance and appropriate criteria. So numerous societies have published guidance specific to their country, population, and health economy. In this lecture, I'll review and compare this guideline, specifically respect to the performing of cardiac CT, focused on ASCI guideline, which was published in 2017, and SCT guideline, which was published in this year. In terms of diagnostic accuracy for CAD, anatomic imaging of CTA or CTA-derived fractional flow resolve, named as FFRCT, and CT perfusion can be used for diagnostic strategies. Current statistical guideline suggests that with conventional angiography, more than 50% diameter stenosis as a reference, CTA, MRI, and PET are the most sensitive and specific modality. However, SPECT and stress echocardiography are less sensitive and specific. With invasive FFR less than 0.8 as a reference, CTA, MRI, and PET are the most sensitive, and MRI and PET are the most specific. CTA is the least specific, but combined with CT FFR and CT perfusion increase the specificity to the level of MRI and PET without loss of sensitivity. However, SPECT and stress echocardiography are the less sensitive. So we should consider that this accuracy data will also be strongly affected by the availability and expertise of the imaging center. This is typical example of diagnosis accuracy between CT and SPECT. Even so, this SPECT shows normal, CTA nicely demonstrates the diffuse three-vessel leads and confirmed by conventional angiography. So, especially balanced three-vessel, in patient with balanced three-vessel leads, SPECT can show normal. So, there's a reason why SPECT is least sensitivity. So let's move on to the next topic. So current in patient with stable CAD, CT is recommended is appropriate except ECG interpretable and able to exercise with low pretest probability. So there are many kinds of various guidelines, and the difference between various guidelines such as ACC, ESC, or NIC from UK, and ASCI might be attributable to advance in CT technology, which have resulted in reduced radiation exposure, more accurate evaluation of small structure, with the improvement in temporal resolution. In addition, wide availability of CT in Asian countries compared to CMR, which is less accessible, could be another cause of the improved rating of cardiac CT in ASCI guideline. So, in addition, CT has a potential merit for the evaluation of CAD in terms of plaque composition as well as stenosis degree. In this case, we can easily identify stenosis degree, but we can also analyze the plaque component. This patient shows many fibrous component compounded by virtual IVUS image. Compared with the other guideline, unique guideline of ASCI is the use of cardiac CT in the evaluation of Kawasaki disease. Because Kawasaki disease is common in Asian country, this recommendation reflects ethnic difference. Therefore, we should keep in mind that CT has a merit in the evaluation of etiology, including non-atherosclerotic disease. In this case, this kind of coronary stenosis due to ISPO-related vasculitis, as you can see. Current guideline recommended that it is appropriate to perform CTA as the first-line test for evaluate patient with no known or known CAD who present with stable, typical or atypical chest pain. Also, it is appropriate to perform CTA as following a non-conclusive functional test in order to obtain more precision regarding diagnosis and prognosis. CT-derived FFR and CT myocardial perfusion to evaluate the functional significance of indeterminate stenosis is also maybe appropriate. However, it is rarely appropriate to perform CTA in patients with very low-risk symptomatic, such as those less than 40 years of age who have non-cardiac symptoms. In patients with acute chest pain, it is appropriate to perform CTA as the first-line test, especially non-diagnostic ECG or equivalent cardiac biomarker. In this article, the authors suggest that it is compared to other guideline, this authors suggest that CTA is more appropriate test where the diagnosis of ACS is equivocal, which is more in line with the ASEAN guideline. So, especially variant angina is common in ASEAN country. This patient showed severe stenosis without distal flag with the LAD, suggesting active variant angina. So finally, on the basis of this CT finding, our clinician performed ergonomic provocation test here. So finally, confirmed as active variant angina. So this is this entity is also common in especially Japan and Korea. CTA highly accurate for the assessment of prior left main coronary stent or coronary artery bypass graft patency. Current guideline also suggests that it is appropriate to perform CTA in patients with prior CABG, particularly if graft patency is the primary objective, or symptomatic patient with a stent diameter more than 3.0 millimeter. However, it is mandatory as following, such as strict heart rate control, iterative reconstruction, or sharp corner reconstruction will be required, or if possible, monoenergetic reconstruction will be helpful. It may be appropriate if patient had stents less than 3.0, but especially those known to have thin stent structure in proximal non-bifunctional location. CTA is also very useful method for the evaluation of prior high-risk surgery in the current guideline. And also, it is appropriate to perform CTA prior to non-coronary cardiac surgery or prior to non-cardiac surgery in selective patient, or redo cardiac surgery is also appropriate. Actually, cardiac CT is also useful method in the evaluation of complex region before PCI, such as great total occlusion bifurcating region. So our institute already reported that, like this one, CT is feasible and non-invasive useful tool to identify high-risk flag characteristics in patients with coronary bifurcating region. However, still, cardiac CT is uncertain in the evaluation of cardiomyopathy after ischemic etiology rolled out. So current guideline also, SCT guideline suggests that CTA is useful for excluding carditis in patients with suspected non-ischemic cardiomyopathy and provide the information on cardiac chamber function and morphology. So in selective patients who have non-ischemic or ischemic cardiomyopathy and who cannot undergo cardiac MRI, rate enhancement CT, similar to rate enhancement MRI, may be performed for detecting infiltrating heart disease or scar. So this is another example of suspected ischemic or non-ischemic cardiomyopathy. Basically, this patient visited the emergency room due to acute chest pain. So cardiac CT nicely demonstrated normal coronary, but regional wall motion abnormalities. So finally, diagnosis 다크추로 cardiomyopathy. So cardiac CTs can be used in the evaluation of prior to RF ablation in patients with atrial fibrillation or CRTs. So, moreover, current ASCI guideline also suggests that cardiac CT can be used to alternative to TEE, and the primary aim is to exclude LA or LA appendage thrombus, and in patients where the risk associated with TEE outweigh the benefits. So CT is useful. Okay, this is schematic diagram for summarization of potential usefulness of cardiac CT in patients with chronic CAD. So post-run test can be used, for example, in the evaluation of coronary anomaly, or maybe appropriate in patients with non-conclusive functional test. How about in asymptomatic? So ASCI guideline currently suggests that in patients with high risk, this cardiac CT can be used as screening tool, or if patient shows calcium scoring more than 100, in that cases also can be used as a screening tool or risk stratification. So actually, even so, patient shows the calcium scoring is normal. About 4% show has non-calcified plaque, so it is not negligible. So therefore, cardiac CT has a limitation in terms of stenosis degree as well as plaque composition, such as high risk plaque. So current ASCI guideline suggests that CTA is appropriate in selective asymptomatic high-risk individualization, especially in those who had a higher likelihood of have a large amount of non-calcified plaque, such as young individuals who have risk factors such as diabetes, HIV, smoking, or strong family history, or inflammatory condition. However, it is still rarely appropriate in asthmatic subjects with low or intermediate risk. So finally, I would like to talk about the role of cardiac CT in the era of COVID-19. So in last year, Dr. Gang from ASCI Medical Center, he wrote this kind of review article. So he already reviewed and summary of the guideline of Cardiovascular Imaging Society in terms of cardiac imaging in the era of COVID-19. So we should consider non-invasive imaging alternative to semi-invasive or invasive imaging in patients with suspected COVID-19 patients, such as if for example, this kind of invasive coronary angiography can be replaced by coronary CT or cardiac CT with or without delayed pace. Also, we should consider conservative imaging. So basically, we can use this kind of various protocol, but however, in patients with suspected or confirmative COVID-19 patient, we can modify this protocol. Okay, we should consider time consideration if you apply cardiac imaging method in patient also suspected or confirmed COVID-19 patient. So this is a list of indication, for example, elective or semi-urgent indication or urgent indication. So on the basis of patient condition, we should select various exam or time, scan timing. Also, we should consider alternative imaging. So this is a list of indications. So this is also a list of usual care. But in patient of COVID-19, this kind of suggested protocol, usually cardiac CT is recommended as alternative protocol. So, however, some various CT protocol will be required for replacement of invasive angiography or TEE. However, we should keep in mind that in the era of COVID-19, cardiac CT is more useful method and more safe method for patient and clinicians' safety. So in conclusion, comparison of international guideline remains problematic as society update their guideline and at different time as the evidence base evolves. More recent guidelines support increased indication for cardiac CT, which is likely in response to the increasing evidence base predicated on improved prognosis and clinical outcome. Thank you very much for your attention.
Thank you, Professor Sang Yin Choi, for the interesting speeches, interesting lecture about the cardiac CT guideline. So for the Q&As, we moved to the end of the session. Okay. And now, Dr. John Ho, please.
Okay. Our next speaker is Dr. Joseph Sherp from North Carolina. I think most of us who do cardiac imaging know his name very well and have met him or talked to him, and he's presented at previous ASCI meetings. I won't go through his CV, but I think most of us have read his papers and he's published extensively. I think it's 3 a.m. in North Carolina, so I think he's not here with us. So I think maybe we'll just start listening to his talk, which is on functional CT imaging of myocardial ischemia.
Hello, everybody. Thanks for tuning in. I'm Joe Shupp from the Medical University of South Carolina in the United States. It's a true pleasure and honor to be able to speak at such a prestigious conference, although believe me, I would much rather be there in person in beautiful Vietnam and Da Nang and have cocktails with you. I hope we can do that in a not too distant future. So let's together examine the topic of functional CT imaging of myocardial ischemia. Here are my disclosures. I have industry ties with the companies that you see listed here. Now let's first look at current CTA and the current evidence of the state of the art. You know the latest from the CONFIRM study that CT is a powerful tool for prognosis, especially if you combine features of coronary artery plaque with the degree of stenosis. We were a little bit disappointed by the results of the PROMISE trial. Everybody in the field was hoping that CTA would be a clear winner in that comparison between a CTA-based analysis strategy versus conventional testing. That unfortunately was not the case, which let many of us down. We had much better data from the Scott Hart study, for instance, that showed that patients with the standard of care fared worse in terms of death from coronary heart disease or myocardial infarction than those who were initially worked up by CTA. So that is exactly what we are hoping to see. Last entry, the ischemia trial, again reconfirmed us in our belief that coronary CTA is truly a powerful gatekeeper before anybody should go to the catheter. The problem that all these approaches have in this aforementioned studies is that we're dealing with the problem of anatomical assessment. That is something that coronary CTA shares with invasive catheter. Just looking at the anatomy and structure of a lesion in a coronary artery doesn't really tell you how severe it is and whether it has any effect on myocardial blood flow. So a lesion that is rather low in diameter can indeed be flow obstructive, whereas even 90% lesions can not be flow obstructive. So that's what we're dealing with. So we need to do better. We need to raise the bar. So how do we do that? We look for lesion-specific ischemia with CT. And we do that because we know that patient outcomes are improved if only relevant lesions are treated that actually have an effect on myocardial blood flow. Traditional methods to detect lesion-specific ischemia were always based on functional nuclear perfusion imaging, an invasive test, possibly including fractional flow reserve derivation. What we're trying to do now is to replace this all with CT, with techniques such as CT-based perfusion, or CTA-based fractional flow reserve derivation. So let's first look at myocardial perfusion. And to do that with CT is not a new idea. We're just applying new technology to an old concept. Those of you who are old enough to remember electron beam CT technology, that instrument was designed precisely for the purpose of measuring myocardial perfusion. It was only later hijacked for coronary artery calcium. With modern CT scanners, we have various approaches towards looking at myocardial perfusion. We have single energy CT-based static perfusions that sometimes allow you to detect old or even a fresh infarct. We have a dual energy CT that looks at the blood pool to find areas that do not receive enough blood. Or we have dynamic CT perfusion techniques that follow the bolus of a contrast material through the myocardium. So what is the goal? Here we have a patient who has a stenosis of the first diagonal branch. We want to know about this non-invasively. And this is the first patient who ever underwent a dual energy CT scan to the heart, and it was at my institution. The dual energy CT coronary CTA shows us the stenosis caused by calcified and non-calcified plaque, so we can see morphology. With dual energy CT, you're looking selectively for the presence of iodine, the blood pool within the myocardium. And you can also do that with dual energy CT by mapping out the iodine content within the heart. And the absence of iodine obviously indicates the absence of blood. That correlates beautiful with the traditional functional test of SPECT that you see here. And you can do that with modern machines with very low radiation doses, like here 2 millisievert for a perfectly fine dual energy CT coronary study. So that helps us to accomplish the goal of looking at both structure and function. We see the atherosclerosis, we see the stenosis, and more importantly, we see what those lesions do to the blood flow to the heart, mapping the iodine out to assess for perfusion defects within the myocardium. I'm always surprised with subtle technology that we can detect. Look at this study, for instance. This patient has a myocardial infarction, as you can see on the MRI study. This patient also has infarction involving the papillary muscle. And you can only see that with structural techniques such as MRI or dual energy, whereas nuclear medicine studies completely miss that. Here's another another example. This is reversible ischemia with a perfusion deficit in the anterior septum that goes away during rest. So picture book reversible ischemia. This is the dual energy CT study that gives us much more information. Yes, there's reversible ischemia, a perfusion deficit that's here during rest, during stress that goes away during rest, as confirmed by the nuclear study. But we also see what causes this. We see that the left anterior descending coronary artery doesn't appear on our 3D volume rendering because it's completely thrombosed. We also see that a patient has a patent stent in the right coronary artery already. So structure and function, all with one modality. It's also important that we can put a number on what we're seeing. It's important to show that therapies that we employ actually work for our patients in a time of precision medicine, something very important. So we're able to put a number on healthy portions of the myocardium and on diseased portions of the myocardium and tell you in terms of milliliters blood flow per 100 milliliters tissue per minute what the perfusion rate is. Very powerful technology. It has been put to test by our colleague Dr. Ho from Singapore, where he showed basically the principle. This is a patient with a stenosis in the right coronary artery, which on myocardial perfusion imaging induces perfusion deficits that you can see here, and you can measure them compared to blood flow in healthy myocardium. Then you put a stent in, and blood flow to the territory was reversed. And you see that now in the former defect, the blood flow is normal again, maybe even a little bit hyperemic compared to healthy myocardium. So point and case to measure and monitor therapeutic effects, these could be extremely powerful tools. Now let's look what we can do on the coronary artery level. Let's talk about fractional flow reserve derived from CTA. There are several methods. The original one is derived from computational fluid dynamics. That's a technique that's also used in the airspace industry to simulate flow around an airplane wing or in the wind channel for cars. The same principles are applied to estimate the pressure drop before and after a lesion based on a coronary CTA study, which is a normal diagnostic study, so nothing special. No additional medications needed, no additional scanning. Why do we want to do that? We know from the FAME studies that patients benefit the most if they're treated only if they have a lesion-specific ischemia. So if patients are intervened on that have normal fractional flow reserves, defined as greater 0.8, those patients don't benefit from intervention. Whereas those who have lesion-specific ischemia with decreased flow values actually do. To differentiate those, what traditionally has been necessary is fractional flow reserve invasively measured to obtain that pressure gradient of more or less than 0.8. That technique is based on a fairly large and rigid instrument that I honestly would not want to have in my coronary arteries. Coronary CTA comes to rescue. The first step of FFRCT analysis is the segmentation of the coronary tree. And based on that segmentation, the flow simulation is carried out. What would happen in that vessel during maximal ischemia. And that then helps you to determine the pressure values within that vessel and put a number to it to see how much the pressure drop-off is in this vessel. And you can also simulate what is happening if you were to put revascularization in a patient and treated that lesion with a stent. So you can simulate what the blood pressure, the pressure in that vessel would be at that particular point. Clinical validity of that method was established in 3 prospective multi-center trials, Discover Flow, De facto, and NXT, which all showed very good results in terms of precision for. Main takeaway message is that it improves specificity over the visual inspection of coronary CTA alone. You see how the area under the curve becomes much larger, increasing the specificity and reducing the number of patients that are called falsely positive. That keeps a lot of people out of the cath lab. As I said, there was a high per vessel performance and high per patient performance in all three trials, although the data was slightly different. But that led to FDA clearance of this approach very early in the year of 2014. Meanwhile, FFRCT has shown its superior diagnostic performance vis-à-vis all modalities. These are results from the Pacific trial, where FFRCT, CTA alone, SPECT, and PET were compared for their accuracy for detection of lesion-specific ischemia. And you see that in all those categories, fractional flow reserve comes out the best. Specificity of SPECT seems to be a little bit better at times, but overall FFRCT is the clear winner. The clinical value was very elegantly demonstrated in the platform trial. The study design had one usual care path, and all of these patients went to catheter. The study group went first to CTA with FFR analysis. And if they had no obstructive CID by FFRCT, they did not go to ASCI. The remainder went to ASCI and was obviously treated as non-obstructive CID or was revascularized. Now, the results showed that by the insertion of the FFRCT analysis, 61% of the initially planned ASCIs could be cancelled, which is an 83% reduction. It is obviously a great win for non-invasive techniques. And even better news is that in this group, no adverse clinical events were observed. You can say it's good if ASCI is avoided, but it's bad if patients die after that, like flies, but that's not the case. So it's a very safe technique to exclude obstructive coronary artery disease. And there was another observation. Those patients in the study cohort reported that they experienced a better quality of life, and the approach was substantially cheaper than the invasive approach. And that is rare in medicine, to have a medical intervention, especially a medical test, that saves money and makes people happier. We don't see that very often in medicine, and especially not in medical imaging. It seems like the cost savings are amortizing over time. There's an immediate cost savings, but that increases at 90 days and at 12 months. So even after accounting the cost for the FFRCT analysis. So this is a test that keeps giving and it decreases cost of care over time. Oftentimes our colleagues in cardiology are wary if we do something imaging the coronary arteries, but they can rest assured that we're actually helping them with that. This is the effect of FFRCT on the efficiency in the cath lab. Weeding out all those patients who have non-obstructive disease, our colleagues in cardiology can focus their precious catheter suite time on patients that really need intervention, and they are not performing those money-losing mere diagnostic catheters that nobody really wants. So it helps their efficiency, which is a good argument to buy into. Advanced registry is one of the later pieces of evidence in favor of FFRCT. This looked at in excess of 5,000 subjects undergoing CTA in various parts of the world. The primary endpoint was the reclassification rate between a purely CTA-based versus an FFRCT-based management plan. These are the results. If you look at the initial management plan, just after having had a coronary CTA, there were a lot of questions. There were in excess of 2,000 patients where people felt additional information was needed, and only the rest was randomized to optimized medical therapy or revascularization. But after the insertion of the heart flow analysis, the rate of insecurity dropped wildly. There were only 121 patients left where people felt they needed more information. And again, this is a very safe technique. Look at this, we have a very strong predictive role of decreased FFRCT values for all MACE or for death or MI, versus basically it's completely excluded if you have an FFRCT greater 80. So there are no adverse events in that group. Again, a very safe approach. We've just concluded the PRECISE trial. The PRECISE trial is basically the same study design as the PROMISE trial, just on steroids, with the insertion of FFRCT. We have in excess of 2,000 patients in that trial now, and the data is locked. MUSC was fortunately one of the stronger recruiters in that particular study. So we're eagerly awaiting the results, and we anticipate that it will be much better and less disappointing in the initial PROMISE data. Let me show you some clinical examples. This is a typical history, 55-year-old male with 3 weeks of exertional chest pain. The coronary CTA shows a bifurcation lesion here at the takeoff of the circumflex and the left anterior descending coronary artery. This is a cinematic rendering of the coronary artery tree of this patient. This is the catheter angiography, which shows us that left main bifurcation lesion. And this is the FFRCT analysis that you see here. And we can see that obviously that is highly lesion-specific ischemia in basically the two vessels that are affected by bifurcation lesion. But something that we initially missed was became also evident that this patient actually has a 3-vessel coronary artery disease with also an RCA stenosis. This is how we manage patients at MUSC using CT-FFR. If you perform a CTA study, there are different outcomes that you can expect. Either you end up with high-risk anatomy, meaning a lesion greater than 90%, and those patients obviously go to the cath lab. Most of the time you will have an intermediate lesion, something between 30% and 90%. In those patients we perform FFRCT, and if that's pathologic, then those patients go to the cath lab. If it's in that gray zone of FFRCT between 7.6 and 0.8, patients are being placed on optimized medical therapy and reevaluated for symptoms 3 months later. If symptoms still persist, they go to the cath lab. If they don't have symptoms, they're being put on optimized medical therapy again. If you have FFRCT greater 80, despite the presence of lesions, those patients also go to optimized medical therapy, and if you have lesions less than 30%, the same pathway. The clinical value of FFRCT has been recognized to the extent that it was incorporated early into pertinent professional guidelines. That is also a record to be in the guidelines that quickly. And that's not only true for the United States, that's true for the UK, that's true for the European Union, and true for some Asian countries, where FFRCT is being placed front and center in the analysis of patients with suspected coronary artery disease. So we increasingly recognize that CTA is the ultimate gatekeeper to the cath lab, and CT-FFR is becoming of increasing importance for CTA to perform that role. And with that, I thank you kindly for your attention. I hope we see each other in person soon. Stay safe. Take care.
Okay, so that's Dr. Scherf's talk. I just want to make one or two quick comments before I introduce the next speaker, because this is a mainly Asian audience. Of course, we want functional imaging of coronary stenosis, but unfortunately, CT perfusion is not performed a lot in Asia, partly because it's of the high radiation dose, and partly because of all the artifacts that come with it, and it's very difficult to interpret. As for CT-FFR, which has FDA approval for, I think, 5 or 6 years, It's not readily available in most Asian countries. I think a few research sites in Korea and Japan can send their data to the company, which is based in California. Unfortunately, they charge $1,500 for each case. So most of us can't send it. And also because we have problems to send patient data across to America. So the three major CT cardiac vendors, German, Dutch, and Japanese, have their own FFR software. And unfortunately, even after about 4 years, nobody's had FDA approval. So we're still waiting for that, because I think that will be the solution to the future, on-site in your scanner room. And now there's third-party software now available, being developed, I think mainly in China. So we look forward to that, because I think the CT-FFR in California that most people are using, or Dr. Scherf is using, is not really available for us to use in Asia. Okay, our next speaker is Dr. Mark Dwerk, who's up in Scotland, in Edinburgh, in the UK. It's rather early in the morning for him. He's a cardiologist and chair of clinical cardiology at the University of Edinburgh. And he's going to talk to us today about imaging of coronary plaque. Mark, do you want to say a few words?
Yes, so thank you very much for the invitation. And it's a great pleasure to be here. Like the previous speaker, I just wanted to, it's a disappointment that I can't be with you in person, but it's very nice nevertheless to be with you here. I'm just trying to sort my share screening out. I hope that I can do that in just a second. I might have to, I'm sorry, I might have to quit and reopen this. I'm sorry, it's annoying.
You need to unmute yourself.
Some music, please. Okay.
You're still muted, Mark.
Yeah, sorry, it wasn't letting me do that. Okay, I'm sorry about that. I think this should work now. Okay, can you see that?
Yes.
Great. Okay, right. Well, yes. So again, thank you very much for the invitation. It's a great pleasure to be here, and I've always wanted to go and visit Vietnam, and hopefully one day I'll be able to. But it's nice to join you virtually, nevertheless. So this talks about assessing plaque in the coronary arteries, and actually, my aim really is to simplify everything. If I can, to simplify coronary artery disease down to two main concepts, which is that if you want to predict risk of myocardial infarction, you need to think about how much plaque people have and what kind of plaque people have. And if you want to think about symptoms, you need to think about ischemia. And that hopefully will be the take-home messages at the end of this talk. So the background to this is that our approach to coronary artery disease for many decades has been the assessment of myocardial ischemia and luminal stenosis. And for sure, those things remain important when we think about symptoms. But as we've seen, treatment of ischemia has consistently failed across multiple randomized controlled trials to reduce the risk of myocardial infarction. And on that background, we need to think about other ways of thinking about coronary disease, other paradigms. Of course, we're well used to looking at these images and seeing tight stenosis. And we've known for a while that if you have a tight stenosis, you have a higher risk of having a heart attack. But conversely, if you get rid of that plaque, you don't really modify that risk. Again, if we think about ischemia, we know that the more ischemia you have, the worse your outcomes. So why is it that when we get rid of the ischemia, we don't improve those outcomes? And we know that from Courage, no difference between medical therapy and PCI. And we know that more recently from the ischemia trial, again, no difference between medical therapy and strategies aimed at reducing ischemia. So I guess what's the explanation for this? And I think it's actually pretty simple. It's basically that correlation is not causation. Just because ischemia is associated with adverse events doesn't mean it's the adverse events that are actually related to the ischemia. And I think instead ischemia is just a surrogate for how much plaque you have, and the plaque is what's causing events. If you get rid of the ischemia, you don't get rid of the plaque, and therefore you don't improve the outcomes. Is this a surprise? Well, actually, it's not really. We've known for a long time that if you look at antecedent angiograms, i.e. angiograms done before someone's heart attack, the vast majority of these lesions, essentially all 18% to 68%, are non-obstructive on the preceding angiogram. So most heart attacks are caused by non-obstructive plaques. And if you look in the Scott Hart data set and in PROMISE, there are as many heart attacks in people with non-obstructive disease as obstructive disease. And of course, if you think about the strategies that we have of reducing heart attack, they work on the plaque and the blood, statins, aspirin, PCSK9, but they have no effect on ischemia. And similarly, drugs that are very good at reducing ischemia, good at controlling angina, they're effective at controlling symptoms, but have no effect on reducing myocardial infarction. So we need to get back to the drawing board, and I think we need to get back to the pathology that causes heart attacks. And of course, this is familiar to all of us. We develop fatty plaques in the arteries, rich in cholesterol, and these plaques become inflamed. And the inflammatory cells secrete MMPs, other proteins that weaken the fibrous cap, cause it to rupture. We get a blood clot, and that occludes the vessel. So this is the pathology that we need to think about when we're talking about heart attacks and trying to predict them. So how might we do this? Well, this is the triangle of risk that was proposed by Dr. Fuster, and I think it's extremely helpful. And broadly speaking, there's two main things that govern your risk of having a heart attack. One is your tendency to have plaque rupture events, for these plaques to rupture, and that is governed by how many plaques you have, by what kind of plaques you have, and disease activity. And then there's the tendency of the blood to clot, because not all plaque ruptures cause heart attacks. We know that actually plaque ruptures occur quite commonly and that they're subclinical. So you need both these things, both the plaque and the blood, to come together before you have a heart attack. So based on that principle, can we try to image some of this to try and improve risk prediction? Well, the first corner of that triangle is plaque burden. And put simply, the more plaques you have in your artery, the more likely one will rupture and cause a heart attack. And this is a simple concept, but it's powerful. It doesn't really matter what technology you use to measure plaque burden. It's the same. The more plaques you have, the higher your risk. On CT, we use calcium scoring as a surrogate for the total plaque volume. It's probably not measuring the plaque type, the right plaque type, because it's measuring stable calcific plaques. But nevertheless, it gives us an idea of the total plaque burden, and it provides very powerful prediction, particularly in asymptomatic populations. But we can go a bit further. We can also think about plaque type, because not all plaques have an equal chance of rupturing. And I've already said that I think calcific plaques are probably the wrong type of plaque to image. And these are probably the right types of plaque. This is the so-called the vulnerable plaque. People refer to the thin-capped fibroatheoma. And they have certain characteristics that include inflammation in the form of macrophages, early calcification, this spotty calcification that's different from the calcium you see on CT. They have a thin fibrous cap. They have a large necrotic core and positive remodeling. So each of these are potentially imaging targets that we can use to identify adverse plaque characteristics in the arteries. And again, there's lots of different modalities to use, but I think CT is probably the most powerful and most useful at the moment. And there's two key features that we can assess that I think are of particular value. And one is positive remodeling, this idea that the plaque grows outward rather than encroaching into the lumen of the vessel. And the second is low attenuation, this very dark area in the center of the plaque that is a marker of necrotic core. And there's been a few studies looking at this. This is the classical study from Professor Motoyama, and she demonstrated that in a large population, 3,000 patients who had these adverse plaque characteristics had a much higher rate of myocardial infarction than patients that did not, nearly tenfold increase in their rate of myocardial infarction. Now, that's not to say that all these plaques cause heart attacks. In fact, very clearly it's not saying that, because here you have 294 adverse plaques and only 48 events. But what it does mean is that if you're a patient who develops these kinds of plaques, you're more likely to have a heart attack down the line, whether it be from the plaque that's identified on that scan or other similar plaques that develop down the line. We had a look at something similar in the Scott Heart data set. We looked at patients who had adverse plaque. There were 608 of them, and 25 of them had a heart attack. So again, not all these plaques cause heart attacks, but if you do have these, if you're the sort of patient that develops these high-risk plaques, you are at the patient level more likely to have a heart attack. You are 3 times more likely to have a heart attack. And that was a more powerful predictor than if you had an obstructive plaque in this data set. What it wasn't more powerful than, though, was just your plaque burden. So once you put calcium score into the model, actually the presence of an adverse plaque fell away and was no longer predictive. And that's probably why we've not been using adverse plaque reporting in routine practice. However, we recently did a study where we wanted to take that concept further. So not only do you have adverse plaque in your arteries, but how much do you have? And this concept of the adverse plaque burden. So what is the burden of adverse plaque in your arteries? And to do that, we measured the burden of necrotic core, the burden of the low density plaque in the coronary arteries. And again, we applied that to the Scott Heart data set, nearly 2,000 patients who had CT and were followed up for nearly 5 years. And what we saw is that patients who had higher adverse plaque burdens, more necrotic core of their coronary arteries, had a higher risk of heart attacks. They were 5 times more likely to have a heart attack during follow-up. And this time, this marker of adverse plaque burden was clearly the best predictor of heart attacks. It beat everything else. Risk factors, the presence of obstructive stenosis, your plaque burden, everything. It was the most powerful predictor of future events. And I think that makes sense. If you go back to the pathology, the plaques that rupture are the ones with large necrotic cores. If we can measure your burden of that, that is as close as we can get to the pathology of the disease and understanding what causes heart attacks. So come back to our, Professor Fuster's triangle of risk. We can measure atherosclerotic disease burden. We're very good at that with CT. We can actually measure specifically the adverse plaque burden, which I think will be the most powerful predictors we move forward. What about this second corner, atherosclerotic disease activity? Can we look at this? Well, if you want to measure disease activity, then PET is a very good technique. And this is, I guess, now widely available with cancer imaging. But the basic idea is you inject a tracer that accumulates in the body where a disease process is active. So you can target, in principle, any disease process you're interested in, and this tracer will accumulate in areas where it's active. This is a tracer for calcification. You can see uptake in the bones. You can see uptake somewhere in the middle of the chest. And at the same time, you do a CT so that you can get better spatial information and you can localize activity here to the aortic valve. So we can do this in the coronary arteries, and we can start to measure calcification activity in the coronary arteries. And it gives us different information from the presence of calcium on the CT. This is telling us not about established calcium, it's telling us about activity. And it serves as a marker of disease activity in the coronary arteries. So if you are a patient who has increased sodium fluoride activity, increased PET in their coronary arteries, your calcium score increases over time. If you're a patient who doesn't have any fluoride activity, your calcium score stays the same. And this is at the patient level. At the plaque level, it's the same. Here's a lesion that has fluoride activity in it, increased disease activity, and the lesion progresses over time and the calcium score increases. So we've got a marker of disease activity. Is that helpful? Well, when we looked retrospectively at patients who had had a heart attack, we could see that the culprit lesion, the thing that had caused the heart attack, was lighting up with our PET tracer. Here's the culprit lesion causing the anterior heart attack. The patient has primary PCI, and a few days later we do the scan and it lights up with our PET tracer. That's interesting retrospectively, but what we really want to do is predict heart attacks in the future, not things that have happened in the past. And so we've recently done a study looking at that, nearly 300 patients. These are people all who've got advanced coronary artery disease. They've had stents, they've had bypass, they're already on aspirins and statins. And we followed them up to see what happens in terms of heart attacks. And essentially what you can do is you can divide people into people who have no activity. So these people have burnt out disease, it's stable, there's nothing going on there. And none of these people had a heart attack on follow-up. These people, despite having advanced disease, high plaque burdens, no heart attacks. Whereas people who had high activity, lots of disease activity in their arteries, they had an 8-fold risk of having a heart attack. And in this patient population with advanced disease, activity markers were more powerful in predicting events than assessments of plaque burden or plaque type. There's a big study ongoing at the moment called the PREFER trial, where we're going to see in more than 700 patients whether this assessment of disease activity improves risk prediction in the future. It's not ready for clinical use yet, but I think after this trial, it might be interesting. And then finally, we've got the blood. What about the blood? Can we image that? And actually the answer is yes. Again, this is research studies, but we now have molecular traces, PET traces for new thrombus formation. This is an interesting patient. This patient presented with a collapse, and actually you can work out from the scan what had happened to them. And essentially they presented with a DVT, and you can see the clot here in the patient's leg. This then caused a bilateral pulmonary embolus. You can see the clot here in the pulmonary arteries, and then the patient fell over and hit their head, and you can see the clot at the sites of cuts and bruises to their face. So this is potentially very interesting. If we can measure thrombus formation in the arteries, this is a potentially powerful technique. This is an example from a patient who's had a stroke, and you can see clear uptake in their cerebral vessels. Again, this is another patient, again with a stroke. The stroke was on this side of the brain, and you can see that the culprit's lighting up with the PET tracer. Here's the stroke, here's the culprit vessel. And you can do it in the coronary arteries as well. This is a patient who presented with a heart attack, quite a high thrombus burden. You can see the thrombus on the CT here, and it's clearly lighting up with this tracer. So these assessments are in the research arena, but I think they offer very powerful assessments of what's happening in the pathology in the coronary arteries. So let's bring it back to clinical practice. How can we measure plaque in clinical practice? Well, this slide has been shown before, but CT is assuming a very important role in the assessment of people with chest pain. From the Scott Hart data, we know that if you do a CT scan, it results in a 41% reduction in your risk of heart attacks. Why is that? Well, basically it just means that we direct simple treatments like aspirin and statins to the right patients who have plaque, both obstructive plaque and non-obstructive plaque. And I think if we do those simple things, we can have dramatic effects on people's heart attack risk. This is the NICE guidelines for how they propose using CT. This is how I use it. So I see patients in the clinic. I take a history about their chest pain. If they have non-anginal chest pain, they don't have any features to suggest a cardiac cause, I don't do any more testing. But if they have typical or atypical angina, 2 or more of these characteristics, then I start them on an aspirin, and I start them on a statin, and I start them on a beta blocker. And then I order a CT scan. And then I bring them back to the clinic and I make a decision about what to do next. And essentially, if they have free vessel or left main stem disease, I send them to the cath lab. If they have an obstructive stenosis and they have ongoing symptoms of angina despite the beta blocker, I send them to the cath lab. If they've got obstructive stenosis and their angina has gone away, then I carry on medical therapy. And similarly, if they have non-obstructive disease, I carry on medical therapy with an aspirin and a statin. And if they have normal coronary arteries, I stop all their medications and discharge them from the clinic. And I think this really simplifies decision making. It stops us sending too many people to the cath lab. I use very little FFR CT because I find that most of the time, the key thing is to listen to patients' symptoms, and I decide to send people to the lab based on the symptoms that they describe. And I would encourage you to think about this because I think it's cost effective and useful. So in conclusion, I think myocardial ischemia we know is associated with an adverse prognosis, but it's not the ischemia itself that's causing the heart attacks. This is an effect of correlation, not causation. And so therefore, when you reduce ischemia, you do not improve prognosis. I think ischemia instead is a surrogate for atherosclerotic plaque burden. If you've got lots of ischemia, you've got lots of plaque. And we should therefore focus on the plaque, and we should think about treatments that change the plaque, i.e. statins, and also treatments that change the blood, i.e. Aspirin, clopidogrel, etc. And I think once you start thinking in terms of plaque and not worrying so much about ischemia, FFRCT, etc., then actually things become simple. So I would encourage you to think in terms of plaque. Thank you very much.
Thanks, Mark. Thanks, Mark, for a nice overview. Because as I guess most people, we're all focused on stenosis. Because of the time difference, I don't know whether we want to take any questions for you, so you don't have to stay to the end of the session. Are there any questions? I don't see any questions for...
Questions should be at the end. At the end of the session, we spend 5 to 10 minutes for the discussion. So for the next topics, I would like to introduce Dr. John Ho from Singapore. He's consultant biologist, Mount Elizabeth Hospital, Singapore, and he's founding member of ASCI and past president of ASCI 2013 to 2015. And Dr. John Ho will present the topics CTA, interpretation, CAT, VAS, and Bion. Dr. John Ho, please. Dr. Ho?
Yeah, thank you. Someone's going to run my slides for me. Thank you. Basically a standardized reporting system for coronary CTA interpretation introduced in 2016 and was a multi-society effort developed by the ACR, ACC, ASCI and SCCT. And the aims of having such a standardized reporting system and the potential benefits are firstly to reduce variability and improve consistency in reporting, to improve communication, to make it easier for the referring physician to read and interpret the report, to help clinical management by recommending the best course or clinical pathway for further patient management, and to produce consistent data for quality improvement, research and education. CAD-RADS is meant to be used for two patient groups, those with stable chest pain and those with acute chest pain with negative troponin, negative ECG changes, and low to intermediate risk of coronary artery disease. And in using the CAD-RAD system, there is a grading or categorization system used. And what are these categories? These categories depend basically on coronary artery stenosis severity seen on the coronary CTA scan. So if there's no visible stenosis, this is considered CAD-RAD 0. CAD-RAD 1 means there is minimal stenosis of less than 25%. CAD-RAD 2 means there's mild stenosis of 25 to 49%. And CAD-RAD 3 means there's moderate stenosis of more than 50% but less than 70% present. CAD-RAD 4 means there's severe stenosis present of more than 70%. And if there is total occlusion, this is considered CAD-RADS category 5. There are also modified categories or modifiers that can be used or are used. CAD-RADS 4A means there's single or two vessel stenosis of more than 70%, and CAD-RADS 4B means there is left main disease of more than 50% or three vessel disease that is more than 70% stenosis. N means a non-diagnostic segment or study. G means graft. S means stent. V means vulnerable plaque or high-risk plaque if there are high-risk plaque features present, such as positive remodeling, low-density plaque, spotty calcifications, etc. So for example, you can have a CAD-RADS 3/S. This means there is stenosis present of moderate degree, 50 to 70%, and a stent is present. So for example, this is a CAD-RADS 3 from the original publication showing a predominantly calcified plaque in the left circumflex with associated 50 to 69% stenosis. Here's another example of a CAD-RADS category 3 lesion, short segment of stenosis, and you can see that this is best assessed on the cross-sectional or transverse images, where you look at the lumen at the site of the maximal stenosis and compare it to the normal proximal or distal lumen to estimate the degree of stenosis. Here's an example of a CAD-RADS category 4B showing a stenosis in the left main with calcified and non-calcified plaque of more than 50%. When you're looking at stenosis, should you use qualitative or quantitative evaluation? Currently, qualitative evaluation is still preferred. That means visual estimation of the stenosis to estimate the percent luminal diameter stenosis relative to the nearest normal appearing segment. And this is what we do every day in clinical practice. Look at the lesion in various projections, longitudinal and cross-sectional or transverse sections. You can also perform quantitative analysis using the software on your workstation, and you can get various parameters calculated for you. However, use of quantitative analysis is limited by insufficient accuracy and reproducibility, and so we are still recommending visual estimation of stenosis of coronary CTA scans. Once you have categorized the patient based on the coronary CTA scans, further management is based on the CAD-RADS category. So for example, if there is a mild stenosis CAD-RADS category, minimal mild stenosis category less than 50%, category 2, no further cardiac workup is recommended. If there is a moderate stenosis, that means category 3, functional assessments recommended, and further management recommended is consider symptom-guided, anti-ischemic, and preventive drug therapy and risk factor modification. If the patient has acute chest pain, based on the CAD-RADS categories, the likelihood of acute coronary syndrome can be estimated. I won't go into further detail about these categories. Here's a summary of patients with stable chest pain. CAD-RADS 3, 50 to 69% moderate stenosis, further recommendation is consider functional testing. However, there are problems or issues that can occur when using CAD-RADS. Firstly, you get misinterpretation of the coronary artery stenosis, and this is actually a pitfall of coronary CTA itself, not CAD-RADS categorization, because we can underestimate or overestimate the degree of stenosis on our coronary CTA, or we can miss high-risk plaque features, and this is related to the spatial resolution of current CT scanners. You can misclassify because there is some overlap and similarities for some categories such as N4A, 4B. There are also missing components in the CAD-RADS categorization system. Location and extent of disease. There's no information on location of stenosis, stent patency, in-stent restenosis, volume of plaque, and multiple plaques. If a graft is occluded, there's no categorization for this. If the stent has a complication, such as stent fracture, if there's a coronary artery anomaly, coronary artery ectasia and aneurysm, if there are non-atherosclerotic causes of stenosis such as myocardial bridging, coronary dissection, coronary vasospasm present, if there is LV wall ischemia thinning, if there are lung nodules present, we need to await new revised CAD-RADS categorization systems. You can also get misguided in clinical management because in clinical practice there are many other factors aside from stenosis severity that can influence further management and can be a source of conflict with the CAD-RADS recommendation. Here's an example of a misinterpretation and misguidance by CAD-RADS related to limitations of coronary CT itself, resulting in a false negative case. This is a 39-year-old man with chest pain. You can see on the coronary CTA it was reported as CAD-RADS category 2, 25% stenosis but less than 50%, and the recommendation is no further cardiac workup. However, his chest pain persisted and he was taken to the cath lab, and you can see he's got a significant stenosis in the LAD. So in follow-up of patients, always be guided by patient's symptoms and your clinical judgment. Go to the cath lab if you're unsure because of possible false negative results of coronary CTA scans, especially if the segment of stenosis is associated with calcification. And the ACC guidelines for appropriate use of diagnostic catheterization also support this. For example, if the lesion is less than 50% with calcified and non-calcified plaques and the patient is symptomatic, it is not considered inappropriate and is considered okay for you to take the patient to the cath lab. What about validation of CAD-RADS? Well, in this study in 2018 it was shown there was high inter-observer reproducibility, particularly with expert readers and high quality images. In another study done in 2017, a single center study, it showed there was high inter-observer reproducibility, and CAD-RADS 4 and 5 had high diagnostic accuracy for predicting significant coronary artery disease, and the best cutoff value for predicting significant coronary artery disease was a categorization of more than category 3. And it was found that CAD-RADS was valuable for improving structure reports and helping decision making with high accuracy and reproducibility. Using an automated structure reporting platform improves CAD-RADS assessment data quality. In this study, automated CAD-RADS classification using data filled in by the reader into a software program was found to be more accurate and outperforms manual classification by the reader by preventing human errors. So using automated systems to enter the information by the reader may improve data quality and enable standardization. What about usefulness of CAD-RADS? Is there any difference in clinical outcomes using CAD-RADS? In other words, what's the prognostic value? And what about guiding further clinical management? Any difference in downstream testing? Here's a paper on the prognostic value of CAD-RADS in stable chest pain published last year, looking at more than 3,000 patients from the PROMISE trial data. It showed that CAD-RADS had significant higher value for predicting future major adverse coronary cardiac events compared to calcium scoring and the usual stenosis-based assessments. And CAD-RADS includes both stenosis and left main, and this was because CAD-RADS categorization includes both stenosis as well as left main and multi-vessel disease as well as high-risk plaque features. This is a paper just published by our colleagues in Korea, which was a multi-center retrospective study of more than 1,000 patients, and showed that CAD-RADS had incremental prognostic value compared to calcium score for prediction of future major adverse cardiac events in patients with acute chest pain. And they found that CAD-RADS scores 3 to 4 or 5 and high-risk plaques were associated with major adverse cardiac events. And CAD-RADS improved risk stratification compared to clinical risk factors combined with calcium scoring. What about downstream testing? Well, in this study done in 2019, it was found that for CAD-RADS category 1 and 2, in other words, patients with minimal or mild disease, there is reduction in cardiology referrals and downstream testing. But this is another study just published last year, this year, looking at downstream testing after coronary CTA and CAD-RADS, and they found that of CAD-RADS category 3, where the recommendation is functional imaging, 23% underwent invasive coronary catheterization, and this coronary cath was often used as a second-line test. The high rate of catheterization suggesting overuse with no resulting revascularization, as many of the patients were not revascularized, and the cath conversion rate to PCI was low, and for patients with moderate stenosis, that means category 3, there was a 74% chance of no intervention. And for severe disease, revascularization rate, however, was high, 64 to 74%. So what this means that there are still quite a lot of patients being taken to the cath lab, even with category 2 mild or moderate stenosis. Using AI and machine learning, this may allow development of automated approach to CAD-RADS. This is a study that's just in press using a multi-center international study using FDA-cleared AI software. The CTA scans were analyzed for percent diameter stenosis, plaque volume composition, high-risk plaque, and CAD-RADS. And AI-aided coronary artery stenosis and CAD-RADS were in close agreement with consensus of level 3 expert readers. They use 3 readers and they use AI algorithm. I think this is very, very exciting, because if this software really works, it will make our life a lot easier for daily reporting and also for categorization. And this has cleared it's not FDA approved, but it's FDA cleared.
So what are the future directions for CAD-RADS? Well, current use of CAD-RADS has been variable. It hasn't been taken up by a lot of centers, but the its use is slowly increasing. There will always be inaccuracy of CAD-RADS classification due to limitations of coronary CTA and the spatial resolution of current CT scanners, leading to overestimation, underestimation of coronary stenosis. And so what is worse for patient outcome? Missing a severe stenosis or increased downstream testing, including coronary catheterization. We need an improved template and classification system for CAD-RADS to cover the issues described earlier, such as missing components, such as location of stenosis, coronary vasospasm, etc. Software systems for entry of data are currently not generally available. The most simple means you enter the data by the reader, and then the system calculates the CAD-RADS categorization, or this new software which I've just described, which is all automated using AI. It appears this is more likely to be more accurate, and we await future developments, particularly with AI and deep learning to help us with new software. The functional significance of a stenosis, including input of CT perfusion, rest and stress study results, or CT FFR results, is still not available, and I hope this will be available to be categorized in the new CAD-RADS classification system. As you know, CT FFR is very, very popular now. It can be off-site software using this company called HeartFlow, on-site software from the CT vendors, and now third-party software providers are also providing software to calculate CT FFR. Thank you.
Thank you, Dr. John Ho, for your very interesting lecture. And now we spend some minutes, 7 minutes for the question. Any question from audience? Yeah, one question for Dr. John Ho.
The question is, could you explain more about CAD-RADS, for example, and what will we do after classification? I sort of described it briefly in the talk, but I think it's a bit complicated to go through it here. But basically, it's a stenosis. The classification is based on the amount of stenosis in the coronary arteries. And then once you've decided the degree of stenosis, then the management or recommended management is based on that. You just have to pull out the articles that clearly describe what you're supposed to do. Thank you for the question.
Dr. Mark, right? Professor Mark is there. As a speaker, can you see other speaker? All speaker?
Hi.
Yeah.
Yeah. Okay. So, Dr. Mark White, can I have a question?
Yeah, I mean, I guess something about CAD-RADS. I mean, just be good to discuss it. Is it worth all the time and effort? And do you think it kind of, does it add anything on top of just assessments of this patient has a lot of plaque, this patient doesn't have a lot of plaque? I mean, I think that comes back to my talk a bit. Do we need to go through that whole process of categorizing it in that way? When I think it's just a surrogate of how much plaque you have again.
I have a question to you, okay?
I mean, I agree with that. I mean, it's the CAD-RADS system is imperfect, and that's why it hasn't really been used by a lot of centers. We don't use it in our center, but some people do find it useful. I think we basically need a new revised CAD-RAD system to account for volume of plaque and multi-vessel disease, etc. It's a bit limited at the moment.
Yeah, I mean, I think that, you know, to make CT successful in the future, we need to make it simple, as you said, and I think we need to pick out people who have normal coronary arteries, because that's, you know, no plaque. That's great. We can stop their tablets. We need to, at the other end of the spectrum, we need to pick out people with left main stem and 3 vessel disease that might benefit from revascularization. And then in the middle, I think we need to identify and separate non-obstructive and obstructive disease, and you know, have an assessment of how much plaque people have. And I think if we do all that, then that, I think, it makes the decision making much easier. But it's hard to. The hardest thing in medicine is to make complicated things simple, isn't it? That's a very difficult thing to achieve.
Yeah, for the plaque. Yeah. So when do we do PET-CT for the plaque?
Well, we don't use PET-CT clinically. It's just a research tool for us. I think in the future, it depends what the results show. If we can show that it helps in risk stratifying patients, I think it will be helpful in people who have very advanced coronary disease. So people who have had heart attacks and stents and bypass. And in those patients, you know, they all have lots of plaque. They have high plaque burdens. You know, that doesn't really tell you very much. But what the disease activity marker might do is differentiate people with burnt out, stable disease versus people with active disease. And the active disease patients seem to have higher risk of heart attacks. And then, you know, that might be a way of us saying, well, you know, using more aggressive treatments like PCSK9 inhibitors or anti-inflammatories. But equally, if they've got high plaque burdens but no disease activity, you know, then we don't have to use aggressive treatments. We just carry on their aspirin and their statins. You know, maybe they don't need bypass operations. That I think we can downscale treatments as well. But it's at the moment it's a research tool. And we need more data before we use it clinically.
Okay, thank you. Dr. John Hu, how about the CAD-RAD in practice? Do we use every day, daily?
No, we don't use it.
It's very...
because it's a little... It doesn't cover many lesions that you see, especially, you know, multi-vessel disease is actually...
I see. Yeah, but for other the thyroid, birad, lyrad, and pyrad, especially for thyroid and birad, it's useful.
Yes.
Very, very useful for us. But CAD-RAD is still not performant. Okay, so maybe we close the session here. Thank you so much. Thank you all our speakers, and thank you Dr. John Hu for co-chair with me. Thank you so much. The session is very interesting. Thank you so much.
Thank you very much.
Can we close the session here? Thank you.
Bye.
All right, bye. Thank you.
Bye.
Bye-bye.
To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.